In this clinical overview, we explore tricuspid regurgitation, a condition defined by incompetence of the tricuspid valve, allowing backward flow from right ventricle to right atrium. Severity of tricuspid regurgitation depends on right ventricular systolic pressure, regurgitant orifice size, right atrial compliance, and respiratory cycle variation. Most cases, approximately 85%, are secondary or functional due to annular dilation from right ventricular remodeling. Secondary tricuspid regurgitation commonly results from right ventricular dilation due to left-sided valve disease such as mitral stenosis or mitral regurgitation and pulmonary hypertension. Other functional causes include right ventricular infarction, chronic right ventricular pacing, and electrical dysynchrony leading to annular enlargement. Atrial functional tricuspid regurgitation occurs in older patients with new-onset atrial fibrillation, leading to right atrial and annular dilation. Primary tricuspid regurgitation is less common and includes rheumatic disease, tricuspid valve prolapse, carcinoid heart disease, and endocarditis. Congenital causes include Epstein anomaly and atrioventricular canal defects, along with trauma and radiation-induced valve injury. Pathophysiologically, regurgitation causes right atrial volume overload, leading to atrial enlargement and prominent CV waves in the venous pulse. Progressive right ventricular dilation leads to systolic dysfunction and reduced forward cardiac output. In severe tricuspid regurgitation, the right atrial waveform becomes ventricularized due to systolic backflow dominance. Symptoms are often absent in mild to moderate disease, but become prominent in severe tricuspid regurgitation. Severe cases present with fatigue, exertional dyspnea, abdominal fullness, hepatomegaly, ascites, peripheral edema, and weight gain. Physical examination reveals distended neck veins with prominent CV waves and a rapid Y descent. The liver may show systolic pulsations and hepatomegaly, often associated with ascites and peripheral edema. A holosystolic murmur is heard best at the lower left sternal border and increases with inspiration, known as Carvalho's sign. The murmur decreases with expiration or Valsalva maneuver and is often associated with atrial fibrillation in chronic cases. Electrocardiography may show right atrial enlargement, right ventricular hypertrophy patterns, or atrial fibrillation. Chest radiography demonstrates enlargement of right atrium and right ventricle in significant disease. Transthoracic echocardiography is diagnostic and shows leaflet abnormalities, annular dilation, and right-sided volume overload. Severe tricuspid regurgitation is suggested by hepatic vein systolic flow reversal on Doppler imaging. Three-dimensional echocardiography and cardiac magnetic resonance imaging provide accurate assessment of right ventricular size and function. Medical management focuses on diuretics for volume overload and aldosterone antagonists for neurohormonal control. Treatment also requires management of underlying left-sided heart disease or pulmonary hypertension to reduce right ventricular strain. Surgical repair is indicated for severe tricuspid regurgitation at the time of left-sided valve surgery or when annular dilation exceeds 40 millimeters. Repair is preferred over replacement whenever feasible due to better outcomes and fewer long-term complications. Isolated tricuspid valve surgery carries perioperative mortality of approximately 8 to 9% and requires careful patient selection. Tricuspid regurgitation is predominantly secondary in origin and reflects right-sided volume overload rather than primary valve destruction.